And nowadays, the vast majority of patients will say if there was any price they paid, it was trivial compared to the relief that they got. And what was clear is that the impersonal is more vulnerable than the personal. It's probably rehearsed more the personal, has more affective laden, but people care much more about the personal. But what was extraordinary is you could come in every day for an hour, sit in a chair, get all this attention and go nowhere, that the placebo response was so little in that context. And what I was going to say is, now compare that to the recover trial in these people who are far more resistant, who've been killed for far, far longer.
Welcome to Stimulating Brains.
Welcome back to another episode of Stimulating Brains, the podcast where we explore the frontiers of neuromodulation and brain stimulation by speaking with some of the most fascinating minds in neuroscience. Today I had the huge privilege of speaking with a true pioneer in the field of neuropsychiatry and brain stimulation, none else than Dr. Harold Sackeim. Harold is perhaps best known for his extensive research on electroconvulsive therapy, but his contributions span a wide range of topics from treatment-resistant depression to the placebo effect and other forms and many forms in neuromodulation. As the founding editor of the journal Brain Stimulation and a founding figure in modern ECT research, he has played a central role in shaping both the science and the clinical practice of brain stimulation therapies. In today's episode, we'll talk about the history and future of ECT and other forms of brain stimulation and his thoughts on where the future of neuromodulation is headed. Thank you so much for tuning in, Stimulating Brains. All right, dear Dr. Sackeim, dear Harold, I will have already introduced you formally, so we can directly dive in. First of all, thank you so much for taking part in this. I know your schedule is very busy, so it's a great honor to be able to talk to you about your career and about brain stimulation. And as I think you know by now, we always start with an icebreaker question asking about hobbies. So what do you do if not stimulating brains?
Well, I live on a horse farm in Mennonite Amish country in Pennsylvania. So many of the farms around me, ironically, have no electricity. There are people that live in the 1700s. Wow. When I'm not doing academic work, as I just was this morning, I was feeding the horses and the chickens and the pigs and on and on.
Wow, fantastic! I'm sure that keeps you busy. Yeah. Fantastic. So diving into your work, can you tell us a bit about your academic journey? What drew you to neuropsychiatry and then ultimately to brain stimulation in the first place?
I have a unusual background. I'm trained as a clinical psychologist. I trained at Columbia, Oxford, and Penn, and joined the faculty at Columbia in 1977. At the age of 25, I was a professor there. Wow. And by 30, I was essentially head of biological psychiatry, chief of biological psychiatry at Columbia, and did that for over 25 years. So, sorry for that. Let me... running the most invasive psychiatry group in the world, essentially, for a long time. We were the people that was involved in vagus nerve stimulation, first use in depression. I developed MST, magnetic seizure therapy, I was the first in the world to administer ECT to people in status epilepticus as a method of terminating status. So we did not hesitate in terms of the invasiveness of the procedures we were involved in. And
Yeah. Did you ever overlap? Probably not, but did you overlap with Delgado there?
no, not Delgado. One of my early mentors was Norm Geschwin
Oh yeah.
from the father of behavioral neurology.
Yes.
And in terms of academic journeys, in 1978, I had a paper in Science on the asymmetry of the human face and in its expression of emotion. And that is something that has now been replicated hundreds of times in multiple societies. And that was part of work that I was doing on the nature of lateralization of the nervous system with regard to affective processes. And I was inspired to start that work by my mentors at Penn, Ruben and Raquel Gore, who at the time were heavily involved in laterality research. And they also were among the first in the world to do neuroimaging to look at behavioral phenomena. And that's all. I introduced functional imaging to Columbia in 1980 when we brought the first lab to measure absolute regional cerebral blood flow using xenon 133 inhalation and then later SPECT and then PET. Sort of with that background, with Geschwin, what I was doing was work on lesion locations in the brain in people who had pathological laughing and crying.
Yeah.
And then where the foci was in people with gelastic epilepsy, outbursts of laughter during their prodrome for a seizure, or dichristic epilepsy, crying attacks during seizures. And that work, which was sort of what was the impetus for the Davidson work and all the work on affective processes and linked to the left and right hemisphere and so on, that led to the interest in ECT. Ruben Gore and I were writing a book called Brain, Thought, and Emotion for McGraw-Hill, which we never wrote.
Okay.
But one of the areas that I was looking in was ECT, because ECT clearly was the most effective treatment we had in psychiatry for very, very serious depression, without doubt. It was also a treatment that you could administer without any drugs. The recommendations, in fact, of the American Psychiatric Association was to withdraw people from antidepressants when you were giving them ECT. Our work later showed that that was a mistake. But so you had people who were in many ways the sickest in terms of their affective illness, who got the most well, who didn't have the confounded drugs. And then on top of it, you had an intervention that you could give in a spatially focused way. So that bilateral versus unilateral, to give you an example, at the time, Liz Warrington in London, neuropsychologist, had showed that left and right ECT were as good as the WADA procedure in identifying the side of the brain observing language. That if you did language testing right after the treatment, you were as good as injecting sodium amytal into the internal carotid artery. So, and then on top of all of that, it was a laboratory for learning and memory. Because in an example, Larry Squire, one of our greats in terms of the neuroscience of memory, the distinctions he drew between declarative and non-declarative memory, propositional memory versus episodic memory, and so on, largely came from ECT samples.
Interesting. I didn't know that. Wow. Okay.
That you could produce an anterograde or retrograde amnesia for propositional information, but if you had patients learn mirror writing, sort of a more basal ganglia-based procedure, there was no amnesia for that sort of thing. And that was among the things that got Larry to advance those aspects of memory. So this was, and the research in ECT was horrible. it really was a field that did not have very rigorous. And essentially what had happened is with the introduction of the medications in the 50s and 60s, a whole generation of individuals in biological psychiatry became interested in pharmacology, and ECT was left behind. So it was an unresearched but extraordinarily important intervention for many, many reasons.
Can you very briefly talk about its origins, when it was invented, who were the key players in the very early days, and maybe why it was never researched well before you came in?
Well, I wouldn't say before but ECT was around in a pre-scientific era. It was first used in 1934 as convulsive therapy by von Meduna in Hungary, who later became an American. Von Meduna claimed that the induction of seizures, he first used camphor and oil, which is very painful, injecting it intramuscularly, and then metrazole, essentially a GABA antagonist, which also had issues. But von Meduna claimed that 50% of the patients he treated with schizophrenia had profound remission after a series of these seizures that were induced chemically. And he was fired from his position in Hungary because he dared to claim that he had discovered something that was of therapeutic value, because the universal view in biological psychiatry was that the major mental illnesses were degenerative or congenital. There was nothing that you could do of a therapeutic nature. There was a nihilism with respect to therapeutics. And it was ECT, when tens and tens of thousands of patients were discharged after decades in state institutions. And when it was discovered that it was even better in mood disorders than in schizophrenia, it just changed the whole zeitgeist. And that's what ushered in the pharmacologic era. What people don't, so in 38, in Rome, Triletti and Bini, Italian neuropsychiatrists, realized that it was safer and much more efficient to induce the seizures electrically than to induce them chemically. I would sometimes comment with my colleague Don Klein, who largely considered the father of pharmacology at Columbia, that we would typically see with metrazole, the chemical induction, panic attacks before people would seize. They were terrified of the treatment because this anti-GABA treatment was provoking this massive anxiety attack before the seizure occurred. And the replacement of it with electricity was something that you could ensure that you only had one seizure, as opposed to because of recirculation issues and so on. So it was a much more efficient approach. But again, this was in a pre-scientific era. The person who spread ECT around much of the world was a fellow by the name of Lothar Kalinowski. Kalinowski was a German half-Jewish, who escaped Germany in late 1930s, and attended the second treatment in Rome of ECT. Going to Italy was not a smart idea at the time. So he had to leave again, and he went to St. Anne's Hospital in Paris, which is where chlorpromazine was later discovered, and the term neuroleptic in psychopharmacology was coined. Interesting. I was just there this past summer to help start a national study in France of one of the newest forms of something called FEAST, that maybe we'll talk about in a bit, spatial targeting of this. But he seeded ECT in France, and then went to Holland, and then to England, seeded it there, and then got on a boat and went to New York City. And the fellow at Columbia, at the New York State Psychiatric Institute, who had my job, Paul Hoke, one of the greats in psychiatry, met Kalinowski at the boat and offered him the job right away at the Psychiatric Institute, where the ECT device was built based on the plans of Triletti and Bini and ECT was promulgated across America. And Kalinowski was very influential because, among other things, he really noted that the mood disorders was an area where you had this profound effect. Okay, so all of that occurs before the revolution in medicine of the RCT, the placebo-controlled trial, those findings, that everything that we would do to evaluate an intervention happened afterwards. And in fact, much of our methodology in medicine generally was stimulated by the introduction of the psychiatric drugs in the 50s and 60s. That's where our standard methodology for trial evaluation was really improved.
Interesting. Was that because effects were harder to measure, more subjective, or like why did psychiatric?
It's also because NIMH started a unit for evaluation of the efficacy of these drugs in an empirical way. It was, let's get away from the doctor thinks it works to, and it was a total revolution, and it was applied pharmacologically, and as opposed to being applied to treatment in psychiatry, it's applied to drugs.
Very interesting. That's fantastic. So okay, what happened after that? Was it then that
ECT went down in its use somewhat. It stabilized to some extent in the 70s and 80s. Mm-hmm. And in terms of my work, when I entered the field, the fundamental belief in the field of ECT was that the seizure provided the necessary and sufficient conditions for efficacy. It didn't matter how you produce a seizure, whether you did it chemically, electrically, or now magnetically, that the generalized seizure was the essential ingredient, and that the electricity only contributed to the cognitive effects of the treatment. Now, what was odd was that even though this was by far the fundamental view, and John Otto Ottosson in Sweden, his work in 1960, had really promoted this as the worldview of ECT, nobody had really adopted in practice, because if you ask, well, if the electricity is what's contributing to the side effects and the seizure is what's therapeutic, why don't we give the least amount of electricity possible, but ensure that they have an adequate seizure? That would seem to be what nobody had ever done that. And when I went to the leaders of ECT at the time, people like Max Fink or Dick Abrams, and asked them, where do you set a dial on this machine? There was not a coherent answer. Essentially, the way the field was treating everyone was at the top of the device, the maximum electrical output of each device. And what was unknown was what was the variability in patients in terms of their electrical needs. As a consequence of this work, I'll sort of tell you part of what happened, and then the science behind it. At the time, when I wrote my first ECT protocol in 1979, the average time it took at that time somebody to know their name, where they were, the day of the week, following a single treatment was 8 hours for bilateral ECT and 6 hours for unilateral ECT.
Wow, okay.
Now, with standard treatment in the field of ECT, it's down to 10 minutes. And with the newest forms, the experimental forms, it's a third quicker as well. We're down to just the anesthetic, essentially, in terms of recovery of orientation. That we've done away, and what's beautiful about that is the acute disorientation is highly predictive of the long-term effects on retrograde amnesia. It's the only persistent effect of the treatment. So you have a biomarker in your treatment room that's telling you essentially what the likelihood is of there being a more adverse outcome cognitively. And part of the reason for this is that, one, the electrical waveform that was being used was incredibly inefficient. In all of ECT the field of ECT in many ways pioneered a lot of our knowledge about the fundamentals of electrical stimulation of the brain. What is the optimal waveform for an electrical stimulus? How do you dose it on and on? To illustrate, the sine wave, which was what Chiletti and Bini had originally used, which is a wave with positive going and negative going waveforms. Because the sine wave is slow to reach peak, it takes in the US with 60 hertz electrical output. That's what we have in the United States, 50 hertz in Europe, so that we have 60 positive going, 60 negative going waves. Each wave or period is 8.33 milliseconds. So it takes about 4 milliseconds to reach peak and 4 milliseconds to offset, and then you can have a wave going in the opposite direction. The width of that because it's slow to reach peak, it's as opposed to, for instance, a rectangular or a square wave, it actually raises the threshold of the neuron to fire through the principle of accommodation. It makes it harder to produce a seizure because of the nature of the slowness of its increase. Moreover, because with a brief pulse, the optimal width of a pulse to get neuronal depolarization in all mammals is between 0.03 of a millisecond and 0.2 of a millisecond, in that range, right? We were giving 8.33 milliseconds, right?
Oh, wow. Okay. Yeah.
So, and so the wave, so we were stimulating the neuron well after it had already fired during its refractory and relative refractory period. We were depositing almost all of the energy we were transmitting to the brain in a way that was highly inefficient. And from my point of view, stimulating a neuron after it's already fired is not going to either be effective in producing the physiologic event you want, and probably is contributing to the side effects. So
interesting.
So there was a big there was a change, and that change has not stopped. We just published last month the first comparison in the world of a 0.15 millisecond stimulus to a 0.3 millisecond stimulus, and showed almost patient for patient that you had a lower seizure threshold at 0.15 than at 0.3. That we could even further improve the efficiency of the electrical stimulus. So that was one thing, is changing the nature of the electricity. The other thing was titrating for the individual. And what we introduced was the idea of giving deliberately electrical stimulations that were below the threshold for a seizure, and using ascending method of limits, a standard in psychophysics, to trigger the seizure at the least electrical dose possible. And what we found is, conservatively speaking, there's about a 50-fold range among psychiatric patients in their seizure thresholds. Some thresholds are far higher than others, and that's largely due to skull anatomy. Only a small proportion of the current actually enters the brain. It essentially goes between the electrodes, because the skull is a massive insulator. It's a resistance impedance is on the order of 17,000 ohms per centimeter, while the scalp is about 200 to 300 ohms per centimeter. So you have a massive insulator that's deflecting the stimulus and only allowing a portion of it to get in, and you're producing these massive individual differences. So what the field had been doing was treating everyone at sometimes 20, 30, 40, 50, yes, because in order to get seizures in the people with high threshold, they were treating, and for instance, women have a lower threshold than men. There is a literature demonstrating more cognitive side effects in women. Age is threshold related, and on it, where you place electrodes is threshold. So we were able, for the first time in history, to measure seizure threshold in the human reliably, and among the other things that happened when we did that is we also, in our first work, two major discoveries. One was in the first study, we randomized people to unilateral and bilateral ECT. under double-blind conditions.
Yeah.
And we had about a 10% remission rate with low-dose unilateral ECT and about a 70% remission rate with low-dose bilateral ECT. We managed to make ECT not work, despite the fact that everybody had, by the most conservative criteria, adequate seizures. So that blew out the fundamental theory about ECT, that it's clearly not sufficient to generalize seizure for efficacy. And what our work later went on to show, and it's been replicated, it's now widely adopted across the world, is that the efficacy of the treatment is contingent on both the current path and the dosage within that path, that there's specificity in where in the brain we need to stimulate with what intensity.
Okay.
Right. And so that moved ECT in a whole different place than the original framework. What we also showed is that seizure threshold goes way up, particularly in people who get well during the course of ECT. It's dynamic, that you need 60 to 70% more electricity, greater charge at the end of the course than you did at the beginning of the course.
Sorry, end of course means after several days, or how long is a course normally?
The American Psychiatric Association would say 6 to 12 treatments is typical in America. It's actually a little bit longer. That is something that has changed with time. There's been a secular change in how much ECT you need, but typically it's a matter of you get treated 3 times a week. So at 3 times a week, let's say you need 12 treatments of 4 weeks is your question. And nowadays, most patients are outpatients. This is being done as an outpatient procedure.
Yeah.
So you needed, let's say, 60, 70% more electricity at the end of your course than you did at the beginning. Seizures get shorter. Their EEG expression gets weaker as ECT goes on, and you're getting a massive, essentially, with the treatments, you're getting large reductions in cerebral blood flow and glucose metabolism. We did ECT in the PET suite with A lines in our patients, and fully quantified both CBF and FDG before, 20 minutes, 40 minutes after treatment, an hour later, and then over time. And so we have very clear understanding. I mean, Jerome Engel was the first to report in Science the inhibitory effects of spontaneous seizure, where you get essentially surround inhibition. And we were essentially applying the same model in ECT. ECT was a place where we could pick where the seizure started from. It mattered a lot more, in my mind, what the site of initiation was. So, for instance, an hour after unilateral ECT, all the EEG changes, all of the blood flow and metabolism changes were on the site of stimulation, even though you got a generalized seizure.
Okay.
That what ECT was doing is fooling the brain into thinking you had a focal secondary generalized seizure, and that you're getting the surround inhibition at where the seizure started from, as opposed to necessarily where it propagated.
Makes sense.
And so that then turned into 2 directions. One was ECT is an anticonvulsant. And it is now demonstrated results in massive release of GABA, and that's where we were the first to use it in interact. I spent a couple of years following with the head of epilepsy, outpatient epilepsy at Columbia, following epileptic patients, and I felt it important. This is in the early 80s. If you're going to be doing this deliberately to people, you should know what the spontaneous effects are. And so we established relationships, and when it became clear that ECT was a powerful anticonvulsant, we then used it to treat intractable seizure disorders and patients with status.
Fantastic. Yeah.
And that has now become a standard, for some places, it's a standard procedure as a last resort for status. And but at the mechanistic level, my belief has been that major depression, there's nothing abnormal about being in a depressed state. What is abnormal is that it doesn't stop. That when your wife says she's going to leave you or you get fired from your job, to feel, we're built so that the abstract concepts are going to impact on our mood. It makes us quite vulnerable, and but there's a resilience that most people have. It's the same type of question as to why do 25% of people develop PTSD after trauma, 75% don't. My view is that depression, we are wired to be depressed, basically. And that what's abnormal is that these are disinhibitory states, that it's a failure of brakes, and that the beautiful effect of ECT is that you can, very quite literally enhance inhibitory tone in particular networks. And so that was the anti-convulsant theory that we had proposed years and years ago.
Fantastic. Thanks so much for this great overview. That already, answers quite a few questions that I had lined up. And so I think you said a lot here to unpack maybe a few points. One that I found particularly interesting and did not know is that, this shift of it's probably not about the seizure. It might be the electricity plays a part in the treatment effect for antidepressant treatment effect. And then also the site of the seizure onset seems to play a critical role. So I imagine that spun off as two very, impactful research fields where to understand this better, right? So essentially where to put the focus. And then also if it's not just about seizing generally, in a generalized fashion, what else is it? Like, how does the electricity change neurons, change the reward system, or do you have other thoughts that followed after this that, or from your work or other work?
Yeah, one of the direct consequences of this is that magnetic seizure therapy and focal electrically administered seizure therapy, FEAST, are the two techniques being investigated. They're in international trials. To enhance spatial targeting, to take advantage of this type of thinking and say, okay, where do we really need to go? I was the inventor of both of them. And I spent 10 years with MagStim building the first magnetic stimulator that was capable of a deliberate seizure induction. When we built that first stimulator, we thought we would need a complete electrical supply of New York City. Okay. We had 16 capacitors, coils blowing up, and so on. But it's quite clear that at least in principle, you had greater control over intracerebral dosing with a magnetic stimulus than you did with an electrical one, because you didn't have the skull effect smearing the spatial distribution.
Sure.
And so you could, and the weakness of magnetic stimulation, I don't think it's panning out, is because of insufficient dosing. Mm-hmm. That I just gave some lectures where I showed a slide of what a typical ECT stimulus looks like inside the brain of a monkey, and what at the same site, the same electrode recording, with in-depth electrodes, what a magnetic stimulus looks like. They're not in any way comparable in terms of the electric fields that they're inducing. And so that's the weakness of the magnetic, it's so inefficient in going from current in a coil to current in brain that you don't have anywhere near the control that you have electrically. FEAST is something that I developed around the time that I was working with Mark George. Mark and I were the PIs of the optimization of TMS trial. I had been the senior author on the O'Riordan study that got TMS approved with the FDA that Neuronetics originally did. And I had worked closely on that. And for OpTMS, Mark was coming up. We wrote that protocol at my house in Westchester, and we wanted to improve the methodology in TMS and have an active sham. And to have an active sham, you needed to, under the coil that was not discharging, it was not producing any stimulation of the brain, you had to have the physical sensation of what it would be like to discharge.
Yeah.
And so we put electrodes under it, and we had the ECT company, Mecta at the time, turn down their device markedly down to the milliamps, like 1 to 10 milliamps, so that we could trigger that device by the magnetic coil, the Neuronetics device. And we had to learn, how do you throw an electrical stimulus to a spot? And that's exactly what we were working on with Vahi Amassian, who is one of the gods of brain stimulation, really a wonderful man who passed away a while ago. Vahi had been the chair of neurophysiology in the Bronx at Montefiore, and then later in Brooklyn at Downstate. And he had done the basic work on what is the optimal form of stimulation to get a neuron to depolarize magnetically and electrically. Where is the depolarization occurring? How do you shape the stimulus so that you use them? And so we were working with those ideas, and that's where we came up with the idea that we would change ECT from a bidirectional electrical stimulus to a unidirectional, current flowing only in one direction, with a different geometry of electrodes, where there would be a cathode and a large cathode, a small anode, essentially. And that would give us the capacity to do targeting. And now just recently another modeling paper came out, our work recording in monkeys with FEAST and traditional, and the human trials we've done all indicate that we're getting much more focal stimulation with that technique. The question you asked about the electricity, largely the way I've thought about it in ECT is what the electricity does is it changes the seizure.
Okay.
Because you have to have a large enough population of neurons. Whenever I've shrunk the population of neurons, and you can shrink it by shrinking a pulse width, because of the strength duration functions.
Yeah.
You will have the shorter your pulse width, you'll have the more focal it'll be. Right. So there are a bunch of ways of impacting on the size of the population and how often they're discharging and so on, which will be electrically mediated. I do think that independent of that, we as a field have not gotten up and said, boy, between TDCS, which is in the 2 milliamp to 4 milliamp range, and ECT, which is about an amp, 800, 900 milliamps, we have nothing. The field of neuromodulation has nothing in between. And I know, for instance, I can produce dopamine release profoundly with an intense electrical stimulus. This is microdialysis work that Anatoly Zis, who used to be chair at British Columbia, he did. Microdialysis in rodents, where if you turn up the dial, you get more dopamine release. And if you block the seizure with the barbiturate, you get the same dopamine.
Okay.
And I've used that clinically. Stan Fine used to send us maybe 20, 30 patients a year, Parkinson's disease, who were psychotic because of their anti-Parkinson medication. And at the time, before they were using clozapine a lot, they were using ECT to both, because ECT is both anti-Parkinsonian and antipsychotic. It's very unusual in that respect. But I saw quite clearly that when I turned up the dial, patients would say, how come my Parkinson's symptoms were so much better and lasted so much longer than the time, that there was that. So I think ultimately we will need as a field a type of stimulation-induced pharmacology that has nothing to do with seizures. And
Interesting. So something in between TDCS and ECT. And remind me, you know the history much better. It was before my time, but I heard from Mark Hallett that before TMS was invented, there was electrical brain stimulation that was just painful, and that's why it never took off. Is that like without inducing seizures? Is that right?
yeah, well, yes, it was largely Marsden and Rothwell and people like that, the
Yeah.
neurophysiologists, because the only way they could get twitches was electrically, and it hurt like hell
Yeah.
to do that. And there had been electric sleep. There had been attempts at electric anesthesia. So that was how they were overcoming this, by putting you to sleep. And that was largely Russian. But the reality was that there was no therapeutics.
Yeah. Okay.
No brain therapeutics, and we're in this wonderful era. To give you a sense, who knows how it hold up, but I helped a group in Lisbon at the International Brain Stimulation Conference in Lisbon, the one before last.
Yeah.
I was invited to help this group that had given 3 subconvulsive stimulations in a row to patients in manic episode, 5 patients. A manic episode, and all of them became euthymic within a day. Compared to the drugs, it was 20-something days to get an effect. And I also think that that'll probably work in catatonia. Catatonia, I've never seen a catatonic patient who did not show marked clinical benefit after a single treatment with ECT. There, it's quite clear. ECT works whenever benzodiazepine works. It's that GABAergic effect, I think. But I think you can get that inhibitory response without seizures as well. That if we stimulate in the right way, I think that we will probably be able to treat the catatonic without the seizure. So those are just some.
Yeah, no, so many already. You opened up so many interesting strands. Maybe we can circle back a little bit about like your career broadly. I always like to ask about mentors and also mentees. Who were the key people that maybe influenced your thinking on your long and illustrious way in neuroscience? Maybe in the beginning, who trained you, and what were
Well,
the
a
turning
couple
points?
of things that mattered was my goal when I was completing my training was to be a full-time psychotherapist, and to have an office on Park Avenue in New York City, and do psychodynamic psychotherapy for the rest of my life. I thought talk was all you needed. And
Okay.
that's an admission of how wrong one can be, and how little you know oneself. But along the way, I did my undergraduate degree at Columbia, and then I received the Kellett Fellowship to go to Oxford. And at Oxford, I read PPP, a degree that doesn't exist anymore, psychology, philosophy, and physiology.
Okay.
And my psychology tutor was Dick Passingham, who was illustrious in his work. And the first paper I had to write for him, he wrote 80 papers in 40 weeks. It was that intense. The first paper was, how do lesions of the hippocampus in animals support or not support the distinction between short and long-term memory in man?
Okay.
And that blew me away. I had to go and read original, journal articles, and the Brenda Milner's work, and this stuff. That as a Columbia undergraduate, you never approached anything at that level, and this was undergraduate work at Oxford, and I had a lab with Edmund Rolls. Edmund Rolls was a young. I just wrote to Edmund. And in my lab there, he taught us how to put an electrode through bregma in the rat brain, and ultimately into the nucleus accumbens, and to do self-stimulation of the rat, which was subliminal impact, I guess, because that was essentially my first experience with brain stimulation was in the Rose's lab. And Larry Weisskranz was also a mentor at the time. Larry was a discoverer of blind sight, that if you have lesions in area 18 of the visual cortex, my first grant from NIMH in 1977 was to produce total blindness in people with hypnosis and to essentially do the blind sight studies. And so you could see that there was that progression. And then I went to Penn. And
sorry, how did you end up in Oxford? Why England? How did
Columbia had a fellowship that that they, if you did okay at Columbia and they liked you, they sent you there.
And then Dick Passingham was anatomically focused, right? So it was probably a lot of anatomy there as well. Is that right?
Well, yeah, but he was my tutor for learning and memory.
Got it.
Each subject in philosophy of mind or logic, so each area had, I saw my first psychiatric patients at the Warnford, and so on. So, and then I went to Penn. Marty Seligman at Penn was the reason I went there. I happened to meet him and we really hit it off and spoke for hours and so on. And so they invited me to come to Penn, but I worked with the Gours, who were Ruben was a first-year assistant professor, and Raquel wasn't part of the faculty at the time, and they were very physiologically oriented, and that had an impact. But to tell you the truth, the research that I did at Oxford and largely for my dissertation at Penn was on empirically demonstrating self-deception, providing a laboratory demonstration that people can truly lie to themselves. And that was because I thought that was the fundamental to psychodynamic thinking at the time. And at the time, half the world was saying there's no such thing as an unconscious. It's sort of silly. So I was still on that track, and ECT and that particular avenue was simply a hobby. It was a number of different studies, and to tell you in terms of happenstance, I was offering a graduate seminar in psychology at Columbia on psychopathology. I was a first-year assistant professor, just out, very green, and I invited Rochelle Gittleman Klein, who was Donald Klein's wife, and she was a psychologist. I offered to teach a seminar. Co-teach it in my class, and Rochelle, she was the first to study ADHD kids and what happens to them 20 years later if they're on drugs or not on drugs. She was the one that showed that your likelihood of ending up in jail is part of function of whether or not you're getting medication. Very important work at the time. She asked me what I was doing. I said, well, right now I'm interested in this ECT thing. I have this project, and I was going to do a trial at Mount Sinai, the sign with stimulate, totally the old way, and so on. And she says, there's this guy at Columbia who really needs somebody to help him do research. He's now head of the Alumni Association. He had been the acting director of the department, acting chair of psychiatry. Columbia's largest department in the world in psychiatry. And he had been marginalized because there was a new chair, Ed Sacker, young guy who came from Montefiore in the Bronx. Sacker was the first to show a biological abnormality in depression ever. He did the first 24-hour cortisol measurements, urinary cortisol, and showed that there was a phase advance. And they were cleaning out the place, all of the old analysts and so on, making it into a high-powered neuroscience institute. And so a lot of the old guard was like they fired Otto Kernberg, the father of borderline personality, people of that stature. And so Rochelle said, "Do you mind if I introduce you to Sid Malice, the guy that needs some help, and he wants to do ECT?" And so we met. I wrote a grant. I had never seen ECT in my life before I wrote this NIH grant. There was a site visit. Sid left the site visit after 5 minutes, said, "Harold will answer all your questions." And we got funded. This was at the time, right? It would never happen, and I wouldn't have the judgment today probably to fund me in '79. And what happened was Ed Sacker, tragically, he was a type A. I would see him in the hallways banging on the elevator doors because they were too slow, and he had a stroke, and it left him aphasic, and ultimately, ultimately he killed himself, and and the faculty at Columbia could not decide on who will become interim, and so they chose Sid Mallitz again. So the guy, right, and so now this revered department, biological psychiatry, which had nobody in it anymore, they gave that to me, and I built it back up to where we had 20 physicians, 100 staff. That group also ran the memory disorders program. Richard Mayu and Devon, my deputy, ran the Alzheimer's program at Columbia. Late life depression and a bunch of other directions. So that was happenstance that happened. And then after Sid, in 1984, Herb Pardes came, having been director of the NIMH, and Herb and I were very close. And we did things like be charged with reorganizing the intramural program of NIMH. So we did that together. So
fantastic. Thanks so much. So, lots of turning points and key figures in your career. Then maybe diving again more into the scientific questions. You talked about cognitive side effects already quite a bit, and I think your research really explored exactly that. Can you summarize, and potentially also looking for towards the future, the effects of ECT on depression, but then also the side effect profile. So my current way of thinking, and it's not well informed, I must admit, is that ECT is probably still the most effective thing we have towards treatment-resistant depression. But one key downside might exactly be these cognitive side effects. And I'm saying this because that might be the maybe uninformed word on the street, where probably a lot of that, like based on what you said before, a lot of that might be still based on trials that were run with these sine wave, high intensity types of stimulation. So do you think the view on side effects should have changed already, or has changed already on ECT, and or might change more in the future with better ways to?
There's no doubt ECT has a PR problem, and which often has little to do with the reality of the treatment. Here is how I would put it. There's been incredible progress in not just reducing, but in most instances eliminating the cognitive impact of the treatment. And nowadays, the vast majority of patients will say if there was any price they paid, it was trivial compared to the relief that they got from the patient's point of view, if you inquire. But it is also the case that because there is variability among people, For instance, pre-existing cognitive deficit is one of the predictors of the vulnerability to cognitive effects. So the people who are coming in impaired are going to be the people you worry about more than people, and the elderly and so on. We did a study that was published in 2007 called the Service Study. NIMH paid for it, NIH, where we put assistants at 7 different hospitals in New York City before, and we very closely monitored these patients before, during, and after their treatment, and 6 months later. And what we were able to demonstrate is that these hospitals did not differ in the efficacy of their treatment, but what hospitals differed in is the side effects they produce 6 months after the treatment. And if things don't get better by 6 months, typically, I don't think they're going to get better. And so that was sort of, sort of bottom line gut feeling is, how can we, as the field of medicine, be in a position where, depending on what hospital you go, you're going to have different amounts of amnesia for events in your own life. And so that was part of the challenge to the field is how, because again, this is largely in terms of control over the nature of the electrical stimulus and the dose of it, and where you're putting it. All that stuff, the technical factors. So, for instance, when we controlled for the technical factors, all the hospital differences disappeared. It's all due to differences in technique. So it's one thing to say, so it's going to, and the variability in practice is not only substantial in the US, but it's even much greater across the world.
Sure.
So for instance, almost all of the West is moving away from bilateral ECT. You're seeing a lot more high dose unilateral or bifrontal, whatever. But China is all, I see at least all of the ECT papers that come to brain stimulation, and they're all bilateral in China. So the promulgation of knowledge hasn't been anywhere near as helpful. I don't know if that's unusual, but it's certainly something that I see in the field of ECT. The other thing that people often don't appreciate is that mood disorders are cognitively impairing. That what's typically the case is that there's a double dissociation between the impact of the mood disorder on your learning and memory and ECT. Typically, with a mood disorder, you have an attentional deficit such that you have a hard time taking information in.
Yeah.
And so that what gets in tends to stay in. There's no rapid loss of, no anterograde amnesia at the beginning, but there's less information that's learned. So, so the end product is you learn less. With ECT, what often happens is during the course of treatment, as you get better, your attentional impairment goes away and you can take more in, but for a very brief period of time, you can't hold it. Right? And that anterograde amnesia cannot be demonstrated more than a week or two after the end of the treatment, at least with modern techniques. And that has practical implications because of decision making, going out driving, that sort of thing. You don't want a patient to be impaired. And the more intense, the more treatments you give, the higher the dosage. These are all dose-related effects. But it's trivial because it's gone very rapidly. And more than a week or two after ECT, there's only one persistent effect on cognition that's ever been demonstrated. And that is memory for events in the past. Largely episodic memory for events in the past. We did the only trial ever where we did a matched task paradigm in ECT patients. I did this with Holly Lisenby was the first author on this.
Yeah.
And what we did was we asked people to produce from memory, tell me about all of the natural disasters that you can remember in the last couple of years, all of the major court cases. List them and tell me as many details as you can about these things, as well as your trips out of town, your illnesses in your family, Princess Diana versus your cousin's wedding. And what was clear is that the impersonal is more vulnerable than the personal. It's probably rehearsed more the personal, has more affective laden, but people care much more about the personal. So, in fact, we were the only people to originally, it was found in ECT that if you ask people to rate their own memory on things like the Squire memory questionnaire, again, to Larry Squire, or Broadbent's cognitive failures questionnaire, patients after ECT say their memory is better than it was before. And it doesn't, and those scales don't correlate at all with objective neuropsychological tests, but they correlate with the Hamilton and the Beck. And we showed that, everybody showed that. We replicated all those effects, for instance, in the services study in those multiple hospitals and in our own sample, multi-center studies. So, but showed that if you ask patients a simple, much simpler question, did ECT help or hurt your memory on a, -5 to +5 scale? That the majority of patients say it hurt. They say it 6 months later, and the degree to which it hurt correlates with how much amnesia they have for events in their own life. That we could show it with objective neuropsychological data that the patient's perception is covariance. So that changed our. It's a really interesting phenomenon. Why is it that when you atomistically go and ask, do you have trouble following road directions? Can you lose yourself when you're reading a book? That's the Broadbent type of question. That people say they're much, much better, but if you ask them just straightforward what you want to know, they say, no, I'm impaired, and it objectively is. So that is a lasting effect of ECT. I believe that what you lose if at 6 months, and it can be dense. A couple of decades ago, I asked a wonderful former ECT patient I think, is still in the Vermont legislature, a woman who had been treated at Dartmouth, and was switched from unilateral to bilateral ECT without her consent, without being reconsented, and developed a retrograde amnesia where she was writing checks on a bank account she had closed years earlier. Regularly, she was asking her family members, how is my uncle doing who had died earlier? So that, and when there's a bad ECT outcome, it can be dense and it can go back for years. That's the thing we're trying to truly avoid. She sued Dartmouth-Hitchcock, and the only thing she asked for as a suit is that she thought ECT saved her life, and that is that Dartmouth-Hitchcock produced a video that was much better informative for patients of what it's like to go through ECT and what the risks and benefits were. And the Mecta Corporation provided that video to every ECT provider. I mean, it was a win-win for everybody. And when the Vermont legislature was considering banning ECT, she had me come up and give a 2-hour lecture to the Vermont legislature on the benefits of it. So when people like that, this is just a sort of a clinical thought. I embraced her and asked her to write an autobiographical account of what it was like to go through this amnesia. But people are so afraid of people who are saying the treatment hurt them that they're typically pushed away and isolated. And that is not how you make friends with in our field.
Of course. Yeah, that makes sense. That's very enlightening. It's still like, one key question is still like, if everybody would do it the proper way, right, with the newest and latest, most minimal electrical field. So maybe, I've just heard a talk by Side Deng, speak at ANPA in Montreal, and he, I'm sure you know his work, and he uses also, does a lot on ECT and E-field modeling. His talk was very similar in scope of what you said in the introduction about all these things with, people will just use the highest voltage that the device produces, and then they don't, like, he also talked a lot about skulls varying and so on. So it reminded me on all the groundwork you were doing now, maybe with e-field modeling and so on. But it seems like this, as you alluded to too, that this knowledge has not translated to the mainstream caregivers. You mentioned hospital variants. So do you think that could hurt meta-analysis going forward, right? If some sites do it the old way with too much voltage, so do you think if everybody were doing it the proper way, would how strong would the adverse effects still be? Is probably what I would love to hear your opinion on.
Well, I think we are far better informed as to how to do it, and it's having incredible penetration. The more recent guidelines from Australia, ultra brief right unilateral is the way that should be your default treatment. I gave the note to Japan, the Japanese psychiatrics, and they asked me to be polite ahead of time. We negotiated for a year about this keynote because they knew that their practices were needed to be updated. And we just taught a course at Brain Stimulation in Kobe, where the leadership in Japan attended the course. I think that the great deal of progress is being made. But I think that it's like anything else. If I have somebody that's going to die, I've had cardiologists beg me to give them ECT with unstable aneurysms, because they knew that the patient had stopped eating and was not going to survive unless, despite all of their cardiac risk, that it's always a risk-benefit trade-off.
Of course,
But another example, I had a kid that grew up in my house, one of my son's best friends, who got a psychotic depression a couple of years ago, and fortunately ended up in a private hospital in New York. Did not respond to medications in the first week or two, and went right to ultra brief right unilateral ECT, 6 treatments, and now it's been 3 years completely well. And
fantastic.
That's sort of, so one thing I would want to mention, and this will be a little bit conservative, but I've been thinking and lecturing a fair amount on the question of, are people born treatment resistant, or do we make them that way? And I believe we make them. I believe that just like there's an antibiotic resistance, which is a function of exposure to ineffective treatment, the exposure to ineffective treatment in psychiatry in particular results in the next treatment being less likely to produce a benefit. So the example I give is, for instance, when you stop smoking, it takes 7 months for your nicotine receptors to regenerate and in your brain, and you're clouded, confused for that period of time. When you come off an SSRI, you've put your brain in a place that it's never been in nature. And you've downregulated a whole bunch of 5-HT receptors, and you flooded the synapse with serotonin and so on. And I think it's not unlikely that experience of ineffective treatment promotes resistance. So John Rush and I have been writing a lot about difficult to treat depression and treatment resistance. But a good example is in the VNS trial, the RECOVER trial that we're doing right now. He and I are on the steering committee for this. The average length of episode for these people in this trial, the major depressive, is 18 years in a depression.
Wow. Average, okay.
The number of failed treatments is 13. Right? Now, in epilepsy, if you fail 2 anticonvulsants, you're a candidate for surgery. That's what it's looking like in depression as well, that the likelihood of responding to the next one is so low that so going on for 13 of them is sort of like, I think, putting pillars into the sand.
Yeah, yeah.
And unlike oncology and other fields where we start with the most potent treatment, what we often do in psychiatry is start with the least potent treatment and build up. But that assumes that there's no residue. And so that's I'm actually more iconoclastic than that. I lectured on this once in Germany to the German Psychiatric Association. And I argue that many of our antidepressants keep you sick. That what they do is they prevent the resolution of the episode. They freeze you. So that your brain is frozen in a place that has never been, that you're half well, you can't get off the drug because the drug is helping you to some extent. It's providing some relief. And if you take it away, you get worse. But it's not, but when I first started in this field, in the 70s, classic patient was a patient who had ECT in their 20s or 30s, had a great life afterwards, and then in their 60s, 70s had another episode. The patients you're seeing now are chronic. And the model that we've switched from was depression was taught to be an episodic illness with a natural history, typically of an episode of 2 years. That was pre-ECT, pre-drugs. That's what the average length of stay in Europe was for serious depressions, for hospitalization. Now we've switched to a diabetes model. And we've switched our models of these illnesses without asking why. And yes, I think the neurostimulation treatments, not just ECT, but TMS and some of the others, because of they're working through a very different mechanism, and they don't have this glue that they're putting in the brain, may have the possibility of both being more effective and not resulting in a higher level of resistance.
Very interesting. Yeah, that's very insightful. A lot of food for thought. Yeah, thank you for sharing that. It makes a lot of sense intuitively to me. Yeah, absolutely. So maybe switching gears a little bit, you did mention Parkinson's disease. I knew about animal studies around ECT in models with Parkinson's disease that are ongoing and suggest, that there could be a great effect of ECT in PD, potentially even disease modifying, which in a degenerative disorder such as Parkinson's is a magic word, right? Of key impact. Do you see value in going into humans or going back into humans with ECT? Is this being done? And if so, why? And if not, why not?
I don't see that it's going to have much potential, honestly. The Parkinson patient was studied quite well, typically in Sweden, with sham. There's been a couple sham controlled trials of just anesthesia alone versus ECT with seizures and so on, Parkinson's. And there's no doubt ECT is anti-Parkinsonian. And there's no doubt that it is a liberator of dopamine. You're pushing your foot on the dopamine pedal, and its clinical role was largely in the patient who couldn't tolerate the doses of L-DOPA or dopamine agonists because of the psychotogenic effects of those drugs. They were just going too crazy. And so here you had an intervention that was both anti-Parkinson and antipsychotic. And so that was one way of managing them. And that's why people like Stan Fahn's group would send us regularly so many patients. But now they're being managed pharmacologically, largely with and particularly clozapine seems to be a favorite agent for dealing with that. And what happened with as I said, pre-existing cognitive impairment, pre-existing brain damage is a real vulnerability factor to the cognitive effects of ECT.
Mm.
And no matter how soft you do it, you're gonna worry about that impact on the Parkinson patient. I remember a classic patient, a private patient with Parkinson's disease that was sent to us, who was at the Milstein Pavilion at Columbia, who was free and dancing and euphoric and so on, but completely disoriented and trying to get out of the hospital. And that we had improved the mood, improved the Parkinson's disease, but the guy needed one-to-one because of the
Confusion. Yeah. Okay.
yeah. So that is going to be a limiting factor. But again, if I'm right, and who knows if you could do it targeted in terms of where in the brain, and two, without seizures, because if it's being mediated in part, at least the pro-Parkinson effect, by this dopamine release.
Mm.
That is totally an area that we've not explored.
Okay. So you would see value in exploring that. So essentially ECT without seizures, so sub-seizure ECT, that could be valuable to pursue, you think?
Right, absolutely. And I looked at in neurologic and in psychiatric disorders. I mean, if you could get a GABAergic effect, a dopaminergic effect, depending on where and with what intensity, my son is a emergency room physician at Stanford, out in San Francisco, but he's also CEO of a neuromodulation company. Mm-hmm. And they're stimulating the splenic nerve with developing an at-home ultrasound device to downregulate cytokines in TNFA, and for the treatment of rheumatoid arthritis. And that's all mediated by the release of norepinephrine and acetylcholine. We know that pathway and so on. So the idea that we could do neuromodulation to produce these specific neurochemical changes that may be of benefit in people with neurochemical lesions is, I think, extremely prominent. And you don't see much of that, but another illustration of that is we gave years ago one of the awards at Brain Stimulation, I think a travel award, people that were getting raclopride displacement in the basal ganglia with TMS to the dorsolateral prefrontal cortex. So they were changing receptor density patterns with dopamine multisynaptically.
One more question about ECT, maybe before we move on to the brain simulation journal work as well. You also discussed placebo responses and worked on that a little bit in neuromodulation in general. Can you talk a bit about that?
That's a tough nut. One of the things that shocked me was that in the development of TMS, TMS was a toy for a long time. Yeah. My group and I did the first meta-analysis of TMS's antidepressant effects. And what we concluded was that there's no doubt that it seemed to have antidepressant properties in the early work, but that they were not clinically meaningful.
Yeah.
And what was impressive was how some of that early work, how little of a placebo effect people were getting. And this is when they were doing, 5 sessions, 10 sessions, and so on. Mm-hmm. And then I did with Neuronetics, I was essentially their senior depression advisor, the Reardon trial. And that was barely successful, but essentially had a 15% remission rate at 6 weeks versus 5% with placebo, with sham, at 6 weeks. Their primary outcome was actually at 4 weeks, but they didn't hit the primary outcome, but got the FDA anyway. Then Mark and I did the OPT-TMS trial, and we essentially replicated. We had a 15% remission rate at the key endpoint and a 5% with sham. And as I wrote at the time, I wrote an editorial in Biological Psychiatry that, it's significant, statistically different, but I'm not so sure that a 15% remission rate where you're taking weeks and weeks of daily treatment is all that compared to the 70% I could get with the ECT. And but what was extraordinary is you could come in every day for an hour, sit in a chair, get all this attention and go nowhere. And that the placebo response was so little in that context. And what I was going to say is, now compare that to the recovery trial in these people who are far more resistant, who've been ill for far, far longer. The sham effect that they're having is much, much greater.
Interesting.
And it's why. And one of the differences is that this is a treatment as usual trial. So you're getting VNS on top or sham on top of changes in your treatment. And it could be that, but the point I was making is that I was not impressed so much by TMS's efficacy at the time as by the lack of efficacy of the shams. And that, in my opinion, has totally changed. I chair the medical advisory board for neuronetics and the registry, 175,000 EMS patients, and the efficacy there is very impressive. And I think it's a moving target. I think it'll get better and better. But I don't think we have a good handle on sham. In ECT, there were in the 60s and 70s a series of 8 studies, I think it was, in England that they were obsessive, repeating sham trials, ECT versus anesthesia alone. And what I took away from the sham trials is, yes, acutely ECT giving electricity and seizure works better than sham, but it's also the case that the dose of the anesthetic agent you're using correlated with the efficacy, with their sham efficacy. That these are GABAergic agents that we used to treat depression by putting people to sleep with barbiturates.
Sure.
And so I don't think these were neutral interventions. I think there was a dose-response relationship there.
Yeah, very complex and very important work. To
give you an example, Stanford at Columbia, actually, we were talking about him before. I believe they were the first people in neurosurgery to do a placebo-controlled trial. And these were in Parkinson patients where the idea was to put burr holes in the skull and drop in fetal tissue into the ventricular system, hoping that it would adhere to the walls of the ventricles so that you would then have dopamine growing neurons into the, right? That was the rationale for this trial. And they had a sham group where they did the burr holes and they didn't put the tissue in. And both groups got better.
Interesting.
Right? It was a failed trial because there was a placebo response in the Parkinson patients to having holes put in your head. So sham responses can occur in the most unexpected places.
Yeah. No, totally agree. And is there a clear correlation between invasivity and sham response? Probably, right?
How invasive the treatment is, how much people, I don't know. That's a good question. Okay. I don't know. I don't know if anybody, I haven't looked at it, if anybody has ever tried to manipulate the sham response by increasing it. I know clinically, always, you want to take advantage of any placebo response that you get. You're very encouraged. But this may be helpful in ECT. We did a couple of studies where I told you about the global impression of the patient regarding their memory. We also asked them afterwards, did ECT help or hurt your mood? But we asked the same questions, what do you expect to happen beforehand? Will ECT help or hurt your memory? Will ECT help or hurt your mood? There is no relationship between the cognitive effects and the expectations. If there was a relationship between the therapeutic, the mood effects, and expectation, it was negative. People who thought that they were not going to ever get better were the people who did the best.
Interesting.
Right. That's a condition where it's true blue.
Yeah. Wow. Okay. All right. So as the founding editor of the journal Brain Stimulation, you've overseen the journal's development since its inception. What were the primary challenges you faced in establishing this journal, and have you seen the influence of the journal, influence the trajectory of brain stimulation research? And then maybe how did you even come up with creating a journal in the first place?
Oh, those are a bunch of questions. At the time, I had a couple of fellows who were training under me from neurology, an epileptologist and a movement disorder person, as well as and my work has always spanned across. I was a consultant to NeuroPace in the development of responsive stimulation and so on. Had a deep interest in DBS. I had given a keynote, a plenary lecture at the international epilepsy meetings in The Hague in the 90s, when I first heard on the question, what do seizures do to cognition, actually? And when I first heard about VNS in that context, and was part of the group that convinced the company at the time to start looking at that in mood disorders. So we were doing a ton of work with TMS and developing MST and these. So we were covering a lot of the waterfront in terms of brain stimulation, at least technologies at the time. And it was a no-brainer. It was obvious that this was going to be an emerging field. I knew that this field had incredible future, and that what is obvious now in hindsight, but I think it was a sense of it then, is that the technology was just going to get better and better. When I did my first science experiment at Oxford, there were no computers. I had to use a correlation machine, which was like an adding machine where you put two arrays in and it spits out a Pearson R. And that's all it does, right? And then I graduated to mainframes, and that now we're at a position where a person who's totally mute, we could develop a vocabulary of 150,000 words for them by reading their thoughts, right? With a chip. And so it was that trajectory that I felt was going to revolutionize psychiatry, and I had the good fortune, actually, when I was charged with helping to reorganize the intramural program. I met this young fellow there by the name of Mark George, who was working for Bob Post, and got exposed to TMS through Mark. At that, we became friends while he was a fellow at NIMH, and so that was clear that would be of benefit to the field. And I approached Elsevier with a sort of an unusual request. This was at a meeting in Toronto in the, I don't know, around 2007, something like that, 2008, with the idea of starting a new journal when journals were dying, when print journals were going out of business. and not having a society. That the way journals stay in business is that you have a society around them which charges dues, and as part of your dues, you subscribe to the society's journal, the new DBS Society and the DBS Journal, the TMS Society and the TMS Journal, the ECT Society and the ECT Journal. And I thought that the politics of that, and I had been president of the Society of Biological Psychiatry. I was the only PhD in the first, whatever, 60 years to be president. And there's, I thought that that is not for a new field of medicine. Um, that we didn't have to be encumbered by all of that if you could if it could be done with just a good heart and getting together a group of people who are invested in this field moving forward and see the best science presented. And so when we wrote the mission statement, it was this journal is going to be agnostic to any particular intervention. That interventions are going to come and go. That's not the point. The point is advancing knowledge and helping to treat people. I was not. I was physically ill at the time the journal was going to start, and so and one of the smartest decisions I ever made was I asked Mark George if he would be willing to serve as editor in chief. So Mark spends 2 to 3 hours a day, 7 days a week, literally. We are now getting, I'd say, about 1,300 manuscripts a year.
Wow,
right?
that's it.
Right. So that's 4 or 5 a day, and he reads every one, and he and a deputy editor act on every manuscript, and 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 uh, and he is much more disciplined than I am. And so he was and he has great judgment. So I am so glad that it worked out that way. And
Sure.
and for the field in terms of what it's done, I think the idea of like the original mission statement, the idea of incorporating neurosurgeons, neurology, psychiatry, modelers, engineers, cognitive scientists, the whole gamut of people that are involved in neuromodulation as in one group, treated equally is fundamental. And there is a deep fundamental knowledge. It's our understanding of how to best stimulate the brain is getting better and better, but it's shared across these technologies and we're seeing. So I mean, questions we were asking: why is it that virtually every technology titrates in the current domain, but ECT titrates in terms of number of pulses and the frequency of pulses? That's the question Ding was asking. And we can ask those questions now, because we know enough about these other technology. Or I said, why in the world did Medtronic make a deep brain stimulator that was a constant voltage device? It makes no sense at all from the physics of it. It should be a constant current device, And so
Interesting. Yeah, no, I mean, I guess they changed that back. So by now, so interesting. So yeah, no, I totally agree. As a forum, across disciplines, across brain stimulation modalities, there's tremendous value of the journal. So congratulations and thank you on behalf of many people, I think, to setting this up. The editors of Brain Stimulation also, you mentioned there's no society. The editors also organize an international meeting, which has grown to a major happening over the years. What were some of the most rewarding moments you may have had in the context of these meetings? Can you share some anecdotes or insights?
Well, those meetings to me are very moving. They're personally and in part because it's sort of like your child is now, having their bar mitzvah is how I put it in Lisbon, not in Lisbon, in Kobe. We started out in Singapore. 500-600 people came to the meeting, and we had a decade later 1,700 in Japan, and by all we unfortunately, an example of the growth of this meeting and how they're going to struggle with it in the future is we had requests from about 500 people to be part of symposia. 500 speakers, right? So you divide that by four, that's 125 symposium. We had 30 slots. So we expanded the slots to 40, but 40 times 4 is still 160. And so so what we did for Kobe is we cut every talk in half and doubled up, so that instead of 160, there are 320. And then we moved others into what we called on-demand symposium, putting posters together. It's too many, and these are good stuff. I mean, Mark and our approach has been, as long as it's in the field and it's science and it's reputable science, then it should be presented at the meeting. That there should be a forum for it in some way. And we had 900 posters.
That's a lot.
Right. And so the meeting has grown enormously. That there's no doubt about it. As with the journal is in terms of personal anecdotes. I'm a member of the ACNP, the fellow of the ACNP, the American College of Neuropsychopharmacology, which is sort of the snooty organization for pharmacology. And they have their own journal, of course. Their society, they have neuropsychopharmacology. But brain stimulation has a higher impact factor than the premier pharmacology journal. So in that race, we seem to be doing okay.
Yeah, no, fantastic. No, and I mean, do I remember correctly that you also said that you had to say no to industry sponsors as well because there were too many that wanted to?
This year we didn't have enough spots. Yeah, it's grown too big, and what you see are like in the TMS world, there's like 24, 25 TMS manufacturers. Russia's manufacturing TMS devices. There'll be a winning out. There'll be, some growing and some, that field is moving fast. But there are going to be lots and lots of new industry. We'll see what happens with ultrasound, but
yeah, so much happening these days in the space. Totally agree. Yeah, and probably everybody wants a booth at your conference, so that's nice. So you at the COVID meeting,
you gave a fantastic talk. I really enjoyed your talk. That was
thanks so much for saying that.
It was one of the highlights of the meeting. It really was very, very.
Oh, that's too much. But thank you so much. I'm of course I felt very honored to be there and about the prize as well. So thank you on that and as well. So at that Kobe meeting 2025, you together with Mark George, you also handed over the meeting duties to Maren Bixen and Charlotte Stack, who are senior editors at the journal. How did it feel to maybe hand off that to the next generation? Just relief or?
No, it was bittersweet. Absolutely bittersweet because it was. Mark and I are slightly different places. I'm a little bit older than Mark, but it's certainly a statement of you're closer to finishing than to starting, and so there's some regret about that. And you worry about, is it going to do as well? What I really worry about is if this field continues, does this want to become sort of a junior form of the Society of Neuroscience, where it's like Grand Central Station and it's very impersonal? that is the meeting getting too big for it to be to have the same type of level of interaction that you had in the past. An example, at all six, I held the expert workshop. I chaired it on ECT. And this was an opportunity for anybody in the world who was attending the meeting to come and ask whatever questions they want. And so there was a discussion, a world discussion about ECT and what the challenges to it were and what people felt the needs were for this field and so on. So it's very personal. And I don't know what's going to happen in the future.
Yeah, sounds good. Reflecting on your work alongside with the journal and the decades you've been in the field, are there any new neuromodulation techniques today that you find particularly exciting or do you think promising for the future? You mentioned fuzz, but what do you think is the biggest new kid on the block?
Well, there's no doubt. I mean, in terms of, I lecture a fair amount on my views on where I think neuromodulation is going to go and where it needs to go. Independent of technology, so I'll reverse it. I think there are three main issues. One is who we treat and why we're treating them. And I think all of our interventions are disease-modifying interventions. Nobody ever got depressed because they lacked a seizure. Nobody ever got Parkinson's disease because they needed to be stimulated in the subthalamic nucleus. It's 2 subway stops down from the lesion. And I argue that, at least in psychiatry, the last time we did anything fundamental in terms of disease processing was when a discovery at Columbia and Rockefeller of the spirochete for syphilis emptied half the beds in the world. Right? And whether depression is a great example, we've now made it into a lifelong illness, and our illnesses are remarkably stress sensitive. Whether it's schizophrenia, OCD, anxiety disorders, depression, obviously PTSD. These are all extremely stress sensitive illnesses. And I think we can fix that with neuromodulation. I lecture about that a bit. One of the people's work that I point to is Hulan Hu in China, who has essentially in rodent models been able to demonstrate that stimulation of medial dorsal prefrontal cortex, she can take a WIMP of a mouse who always loses against another mouse in a tube test where you put 2 mice in a tube and has to push the other one out. She recorded single units from the winners, identified the cells that were firing when they were winning, transfected those with a virus so that she could shut them off chemically, and she immediately made winners into losers. And then she did the inverse. She used optogenetics to instantly make a loser into a winner. And then she showed that with 6 experiences of brain stimulation induced winning, half the mice became winners for life. And she worked out what the pathway was in the brain that was altered to the thalamic, right? The same week this came out in Science. I was having dinner with Marty Seligman at Penn, and the neuroscience people who had essentially studied what is the basis in the brain of learned helplessness. And that whole thinking, they essentially had a major theoretical paper where they went, like Steve Hawkins, they went 180 degrees around and said, you know what? Helplessness is the default state. We're born helpless. What we do is learn control, or what I call learn resilience. And there's a neurobiology behind it, and there's a brain center behind it, and so on. And so I think that one of the big challenges for our field is to essentially do preventative medicine, to develop interventions where it's no longer fixing what's broken, but not letting it break. And Uh,
Yeah.
and the problem with that is every military in the world now is banking on this. DARPA gave me my group lots and lots of money years ago to see if we could have pilots flying for 24 hours with a brain stimulation reversal of sleep deprivation. But this is even more. If you could make a socially dominant mouse, imagine what you could do for a soldier, or get your kid into Harvard. Yeah. So that's one issue that I think a lot about is we think disorder or disease based, dysfunction based in terms of our interventions as opposed to the more fundamental question. In terms of technology, it's quite clear that there are two, I think, main goals of the field. One is non-invasive focal pharmacology, and the other is non-invasive stimulation of a deep structure without impacting on the surround. I think the non-invasive focal pharmacology will be easier to achieve, whether it's through uncaging techniques or designer drugs. That is going to revolutionize in the next decade neurology and psychiatry. That once we can send a drug to a spot, and I did, by the way, I did some work with, I don't know if you know Dan Abrams. He was chair of neurosurgery at Children's Hospital of Denver, a consultant to this work. And he was so invested in the focal pharmacology. His specialty was removing glioblastomas from kids, and he started losing his eyesight. Chair of neurosurgery. Right? And so he humbled himself and did a new residency in psychiatry. And while he's a resident, a fellow resident says, wouldn't it be great if we could chew clozapine straight into the brain? He says, I could do that. And what Dan did, what I've helped him with, is he put a pump in the abdomen, under the skin, tunneled a catheter to the ventricular system, put a shunt in the ventricular, and under MRI guidance, guided the shunt to the floor of the lateral ventricle, which is the hippocampus and the amygdala. Mm-hmm. And what we did is we took patients with medial temporal lobe epilepsy who had failed pharmacology, had them all fail sodium valproate at mega oral doses, and then pumped in sodium valproate at 1/10 the dose that they had failed orally, and got 70% seizure control, no side effects. 3 out of 5 becoming seizure free.
Wow.
And I wrote the protocol for Dan's group company, which was called Cerebral Therapeutics, to do that for the DoD, to do that for PTSD, for intractable, because what other area of the brain you want to shut down but the hippocampus and the amygdala in PTSD? And what better way of doing it with an anticonvulsant? And so he had raised, I think, $50 million for that venture, but Biogen bought the hardware for how to do that. So that's an example of the hard way of doing focal pharmacology. If we could do that non-invasive, wow, that's going to be huge. And that's why, by the way, when I wrote the original vision statement for brain stimulation, included focal pharmacology as part of brain stim. That I figured we'd have to use some type of stimulation-based technology to get there. And so at the technology end, yes, ultrasound obviously looks like it's the way. Very excited about it. We'll see. The last thing, the third avenue, and this is some stuff that I'm doing with Abrams now, and many other people are doing it, is obviously the reading the brain. That it makes no sense to stimulate it without reading it. And here I think we have a pretty smart idea. Obviously, this was in part inspired by all the work that's being done in rehabilitation. Like bringing speech to the mute. But what Abrams wants to do is there are 30,000 Americans who have a shunt put in their brain every year for hydrocephalus. Yeah. And the shunts are dumb. The only thing they do is remove CSF.
Yeah.
Why don't we put sensors on the shunts? These people have sleep disturbance, they get panic attacks, they have PTSD, they have traumatic brain injury often, and they hallucinate. And if we can read somebody's thoughts so that we could detect a word, it should be far easier to detect a hallucination or to detect a panic attack. We're not asking what the content of the hallucination is. We're asking, are they hallucinating?
Yeah.
And there, the idea is to use external sensors at the same time as you have the internal, so that you can at least validate some biomarkers on the outside while you're picking up, the real signal inside the brain. So it's sort of leveraging that is we need better signals in terms of our stimulation paradigms. And let's take every advantage we can of what we're putting in the brain. And so that's the sort of stuff I think about.
Love the idea. Yeah, very interesting. So use the ventricular system to, and we're going there anyways to get more insights. I want to be mindful of your time. I know how busy you are. I can imagine how busy you are, and want to ask one last question, which is, you shared your CV with me, and I've probably never seen a CV that's as impressive than this one. You have, I think if you count patents and case reports and everything, you've authored almost 500 articles. If you had to pick just one, could be a patent, could be a scientific article, could be anything. Which one are you most proud about, and what is it about? I'm sure that's hard, right? From 500 things you've put out.
I think the thing that jumps to mind is the 93 paper in New England Journal of Medicine, because that was the paper that both disproved the theory of mechanisms of ECT and at the same time gave a whole new direction in terms of how to treat people.
Yeah.
And so that's, you can see in my work, that's sort of the balance I'm trying, is to get to fundamental questions, but at the same time be very clinical. And
love it. Okay, fantastic. Is there anything I should have asked that you would have loved to talk about more, but that I failed to address?
I should say a little bit about my thoughts about TMS. TMS, who would have known? When I mentioned what the remission rates were with TMS in the controlled trials that got FDA approval, it tells you how much FDA approval means.
Yeah.
It's now, it's remarkably lawful. We're averaging in literally tens and tens of thousands of people, about 70% response rate, a 35% remission rate.
Yeah.
So it's as good as any drug, and probably better in that. And the first trials of failed two drugs, do you get TMS or do you get the next drug, are coming out, and they're favoring TMS. That, I argue, a couple of things. One is that we stopped giving TMS while people are still getting better. That I've been able to track the clinical progress, and it's remarkably lawful, and people had no appreciation for this. There's a 3% improvement per session over the first 10 sessions. In some cases, it might be over the first 5. Then it drops to 1% per session. So there's a two-thirds decrease in its potency, but it keeps at that level until you stop giving it. It's not that people have plateaued; it's that we stop the treatment. And so you have the opportunity to convert those responders who are not remitters into remitters, because insurance is run out, right?
So obviously, because it's so impractical, you're giving it now, if you're giving 36 sessions as the typical number, if you went 5 times a week, that would be over 7 weeks. We know we can accelerate it.
Yeah.
Right. So and I was the one that wrote the view, God knows whether it's really true or not, that the quicker you get well in depression, the quicker you lose it. That the neuroplasticity is such that TMS right now, in standard TMS, daily TMS, I think has a better protection against relapse than ECT. Certainly better than ketamine, far better than ketamine, right? And I think it's with those other interventions, it's in part is they work too quick. So you need it. Yeah. So that's the sort of thing I'm thinking about is we can fashion a form of TMS which has the same type of remission rates as you get with ECT. Not necessarily the same people. It may only work in somewhat less resistant, may not work in the deep resistant patients. Still may need ECT, but we can improve the outcomes with TMS, and I think we can speed it up. I know we can speed it up. What Nolan Williams did. Nolan is one of my grandkids, academic grandkids, and he stays here at our farm and stuff. So I love Nolan's work, but he threw the kitchen sink at accelerating TMS, doing everything possible, and we tried to deconstruct it a little bit. Just with neuronetics, I did a little work with a group in Minneapolis. Clinically, that instead of giving 50 TMS sessions in 5 days, they gave 36 because that's what patients got insured for. Instead of giving 3 times the number of pulses of TBS, they got standard 600 pulses of ITBS instead of 1,800. And they had no neuronavigation. They did not use fMRI to identify the anti-correlated region, which I'm doubtful about its utility. And they got the same clinical effects. Who knows? I mean, they may be less resistant and so on. There may be some advantage to what no one was doing, but basically you can accelerate it in a routine way, which is huge. So we have that power. So now we have to mix it, make the cake in a way which preserves durability, is practical, and it maximizes remission. This is a totally different type of TMS than what we had 10, 15 years ago. It's
it's remarkable. I mean, you could even potentially counter your argument that bumping people out, if it just takes a week, in theory you could do it more often if it doesn't last that long. But I it's very interesting thought that it lasts longer if it takes longer to work. Do you think that is based on plasticity or more on life changes that, essentially becoming non-depressed too quickly, your environment won't adapt to that, or like, why do you think it lasts longer?
I'm glad you asked that. The opposite of what I told you as wanting to be a psychotherapist from the beginning. I think it's biological, but who knows? I'm also one that thought it was bizarre that you could take people who are so profoundly sick, who had tried repeatedly to kill themselves and whose family life had fallen apart, get them well with ECT within 2 weeks. And and not give them psychotherapy. It did not make sense to me, but that's the society we are in. So there may be some component to that, but I think it's some type of neuroplasticity. The psychotherapy takes the longest to get well, and often lasts longer. Pharmacotherapy comes next, traditionally, 4 to 6 weeks, as opposed to the ketamine. Ketamine, you lose it within days, right? Sleep deprivation, half of TRD will get better in one night if you deprive them of sleep, but you can't keep them without REM, and so they all relapse. And all of the not all, but 80% of the relapse following ECT for a year occurs within the first 2 months. You fall off, so if you look at that big picture, it's again something that may suggest that taking it slow makes it last longer. I haven't written it up, don't have time, but Neuronetics, I'm going to have a conversation tomorrow about it. We have a couple thousand people that got treated twice with TMS, and you don't need less. You need to go the full. If you have a full relapse a year later, you need another full sets of treatments in order to achieve the same benefit.
So much still to learn, and so insightful and inspiring. I want to thank you one more time for carving out 2 full hours of your busy schedule, Harold. This was truly illuminating, and again, I want to tip my hat in front of your fantastic career and
thank you.
All the amazing things you've done and are doing. Really amazing. Thank you so much.
My pleasure, and thank you for doing this. Look forward to seeing more of your work in the future. When are you going back to Germany?
In May, actually. Yes, very soon.
Very soon.
Yeah, very soon. Yeah.
Well, for what it's worth, this is a wonderful time to be leaving America.
Yeah, that's a big topic, but it did not influence my decision, these recent events, but it is troubling times. Yeah.
No, I can imagine. Anyway, good talking with you.
Thank you so much one more time. Great.
Okay. Be well. Bye-bye.